Oh, Vanessa, no, it started. Hi, Carmen, how are you?
I am well. How are you?
I'm all right. You see, Vanessa and Ariel said they can't get in.
It was giving me a message.
That's probably because I was late.
Okay.
In some way to appear publicly.
Let's see. Hello.
Hey.
Hello, everyone.
Hi.
Okay.
Hi.
Hello, hello. So, let's see. Is that everybody? Okay. Is are we all no, we're all not here.
I think we're missing, is this Erin here?
I don't think so because her computer screen said Aaron Bowman on Thursday. But she may have tried to get in and had trouble like we did.
Oh, they went away. So I want to put us
That may have
I
been my
want to
cousin. She's tuning in
Oh.
from London, so
Oh, okay.
who knows?
I want to put us into the breakout room, but I need to wait on that. Whew. So it looks quite lovely. Let me see. Okay, so we have over 70 registrants. So that sounds good. Which means we may have about 40. I have learned that people who register don't show up.
We'll see. That's
So
good.
We'll see how they do. And I just posted it again on Facebook about 15 minutes ago, giving people just not the registration, just the join link. And then I'll start on Facebook, exactly how to do that. Let me check that out. Start live streaming. Okay. Someone want to give Erin a buzz, make sure she's.
I just emailed her because Thursday she responded immediately by email. I guess she keeps her work email on her phone, so it's as reliable as texting.
Okay.
So hopefully, I mean, she sent us the slides and she emailed me earlier, around
Right.
6 or so. So
Right. So
I know she's
Yeah.
engaged.
Ariel, I'm going to make you a co-host.
Okay.
Unless I can have to make you one too, just so people who might need to do something.
Okay.
Well, I wonder if I can put the five of us in a breakout room, then when she joins. I really want to. I'm not sure about that part.
I guess while we're waiting, does anybody have any questions or concerns? Okay. I think really one of the biggest things is Erin wanted to have control of her own slides, so we just want to make sure that transition goes smoothly.
Yeah, I just need to make her a presenter. So if she would come on, that would help. Oh, here she is.
Hello.
Good evening.
Hi.
Hi.
I'm going to move us all to a breakout session. So if people join, we can talk without them. I hope this is going to work. Somebody. I only wanted one room.
So the two of us ended up in a room. You look pretty.
Thank you.
Did you wear your hair short in college?
It was
Yes, yes, I remember.
like
Because I guess you were like a year ahead of me.
class of 2000. Year
Yes,
2000.
2001. Yes,
Mm-hmm.
I
It
definitely.
was, I guess it was like shoulder length until maybe sophomore, junior year, and then I cut it to like
I have. Uh-oh.
Hi, sisters. I'm just coming to let you all know that we will be beginning in about 5 minutes. Well, good evening, sisters. My name is Ariel Dotz. I'm a class of 2014, and I'm the moderator for this evening. The Health and Wellness Committee of NAASC welcomes you to our third webinar of this year. This webinar today is near and dear to my heart. Breast cancer took my mother in 2012 when I was a sophomore at Spelman, and her journey with breast cancer has really led me to my journey as a PhD student in the biomedical sciences. So it's very important for us as Black women. Black women have a 40% higher mortality rate from breast cancer than white women. So it's very important for us to raise breast cancer awareness and women's health awareness in general for our communities and to be knowledgeable about the statistics of our community. But before I introduce our speakers this evening, we will start off with a few words from our NAASC President, Kiva Wright-Berry.
I'm trying to get it straight. Good evening, everyone. I am Kiva Wright-Berry, President of the National Alumni Association of Spelman College, and I want to welcome you to our October webinar sponsored by our Health and Wellness Committee. The committee's theme for our 2020-2021 program year is Women's Health Across the Lifespan, or hashtag Women's Health for Life. Tonight's presentation and discussion is entitled Breast Cancer Awareness in Our Own Words. As we know, breast cancer is the most common cancer in women and the second most common cause of cancer-related deaths in Black women. This webinar will be timely and informative for all of our sisters. In our decision to focus on hashtag Women's Health for Life, it was noted that as alumni of Spelman, we should be the ones who own the issue of Black women's health. If not Spelman, where else? We have the knowledge and the talent to fully inform our sisters about ways to maintain healthy lives. So please continue to join us for our upcoming health webinars. We'll have another in February and in April. We look forward to sharing critical information with all of our alumni. Thank you.
Thank you, Madam President. Our first speaker this evening will be Dr. Erin Bowman, who graduated from Spelman College with a Bachelor's of Science in Biology in 2000. Although a Philadelphia, Pennsylvania native, she considers Atlanta to be her second home. Upon receiving her degree, she returned to Philadelphia to complete a master's in biological science before heading to Boston University School of Medicine, where she earned her medical degree. She completed her surgical residency at Morehouse School of Medicine, followed by a breast oncology fellowship at Emory University School of Medicine. She's a board certified by the American Board of Surgery, a fellow of the American College of Surgeons, and is a managing partner of Atlanta Breast Care, where along with her partners, she manages and treats a wide range of conditions from breast pain to breast cancer in a full service and supportive environment. She currently sits on the board of directors of Susan G. Komen Atlanta Affiliate Group. She is a member of the Oncology Governance Council and Perioperative Governance Council at Piedmont Atlanta Hospital. She has been awarded one of Atlanta's most influential women in medicine in 2019 as well as 2020. And with that, I welcome Dr. Erin.
Good evening. Can you hear me?
Yes.
Okay. All right. Thank you so much for inviting me to speak this evening. We're going to put the slides up, and I am going to talk about breast cancer in Black women.
Okay, they're coming.
Again, I'm Dr. Erin Bowman. I am here in Atlanta, Georgia, home to Spelman, and I'm a breast surgical oncologist in Buckhead. You can go to the next slide. Tonight, my objectives will be to provide a brief overview of breast cancer, including risk factors, diagnosis, and treatment options. I'm going to discuss some screening guidelines and current breast cancer statistics. I will also discuss some disparities in breast cancer care and as well as possible solutions to ending breast cancer disparities. Next slide. So what is breast cancer? Breast cancer is actually an uncontrolled growth of breast cells. So we see abnormal changes in the genes in these cells that are responsible for regulating growth and keeping cells healthy. And so what happens is those changed cells have the ability to now keep growing and dividing without control or any order, which forms a tumor. And so you can see this is what the breast looks like inside. And the yellow is fatty tissue, and the pink is what's called the glandular tissue. And the glands are made up of lobules and ducts. The lobules, which is where B is pointing to, those are where milk, protein, those things are made within the breast. They all connect to the ducts, and then the ducts come together and they come out the nipple. Breast cancer can be in either place, in the duct or the lobule. It does not change how we treat it, but there are sometimes different things we look for when we do our workup. Next slide. When we talk about signs or symptoms of breast cancer, the most common thing that we find with women with breast cancer is that there are no symptoms. Most breast cancers are found with screening mammography, but there are some women that do find a mass, and not that it's a painful mass, but rather a painless mass. And it might be found on self-breast exam or found incidentally while in the shower, while getting dressed, or just a change that's noticed. There are some less common signs of breast cancer that we want to educate patients about, or women about, to look for when you're doing exams. And that is like swelling of all or part of the breast, skin changes, whether there's irritation or dimpling of the skin, if it might look like an orange peel, breast pain that won't go away, nipple changes, whether it's pain, retraction or new inversion of the nipple, crusting, nipple discharge, bleeding, redness, scaliness, or thickness of the skin of the nipple or the breast. And then again, that lump in the breast or underarm area. Next slide. So this is just showing some of those warning signs that I just talked about that you will need to seek attention from a healthcare provider. If you have a lump or sores or the changes in the skin, but most importantly, any change at all, then you need to get attention from a medical provider. And just one picture in the bottom and the middle, I just want to point out, when we do exams, it's important to look at the shape of the breast and the actual contour of the breast, because if it doesn't look like a normal circular, shape of the breast that's normal anatomy, there might be something that's inside that's pulling it in. So when you look in the mirror, if you look at the shape of your breast and it looks like a dent, or it looks like one side looks like maybe a line and not a curve, you may want to have that checked out, especially if it's something new, because it could be something inside the breast. Next slide. So some breast cancer statistics. So 1 in 8, about 12% of women will be diagnosed with breast cancer during their lifetime. And men get breast cancer too, but just not as common. 1 in 883 men will be diagnosed with breast cancer in their lifetime. It's estimated that in 2020, and about 276,000 new cases of invasive breast cancer will be diagnosed in women in the U.S. And 49,000 cases just about will be of the non-invasive or in situ diagnosis in women in the U.S. About 2,600 new cases of invasive breast cancer are expected to be diagnosed in men, and 42,000 deaths from breast cancer in the U.S. And those are deaths in women. As of January 2020, 3.5 million women in the U.S. have a history of breast cancer. And so this graph looks at the risk of breast cancer by age. And so we know that as you increase your age, it increases your risk for breast cancer. And you can look at this curve where the curve takes a steep or kind of curves upwards and starts to continue to go upwards at age between 30 and 35.
Beginning in this relationship, you tried to warn Jess about
the increase, and that it plateaus between 60 and 65 and then peaks and comes down. Next slide. So when talking about risks, because we say the risk is 1 in 8, right, which is 12%, we want to talk about absolute risk versus relative risk. And the absolute risk is when we look at a risk that's during a particular decade, so over the next 10 years, right? And so when we look at that, when we separate it by age, then you can see that when you're younger, your risk of developing breast cancer is not as high as the 1 in 8. So that is actually in your lifetime, when we say it's by age 80 or over your lifetime, that the risk is 1 in 8. But if you're 20, your risk of breast cancer is going to be 1 in 1,732. So not as high of a risk. However, that could change based off of a number of factors, particularly family history and genetics. The relative risk is something a little different that we look at, and that defines the risk related to one group when compared to another. So I get the question all the time about what increases the risk, and does alcohol increase the risk? And it does. A woman who drinks 2 or more alcoholic beverages per day has a 50% higher risk of developing breast cancer. But what that means is that they are 50% more likely to develop breast cancer over the course of their lifetime when compared to someone who doesn't drink. So if we do all the calculations, it's actually that someone who drinks has an 18% risk, whereas the normal population has the 12% risk. Next slide. Next slide. Sorry. Oh, one slide back. Oh, maybe it's not. Okay, you can go ahead. So all this about risk factors. We don't know exactly what causes breast cancer. We don't know what triggers those cells to go from normal to atypical to cancerous. But we do know risk factors that will increase your risk for breast cancer development. And we know that there are risk factors that you cannot change. One is being a woman. That is one of the biggest risk factors for developing breast cancer. The second is increasing age, and that you also cannot change. Your family history, reproductive history, or exposure to natural hormones. So that's going to be like, how old were you when you had your first period? At what age did you go through menopause? At what age did you deliver your first child? Really what we're looking for is your exposure to those natural estrogens. Your genetic history, whether there's a known genetic factor or known genetic mutation in the family, that would increase your risk. And then a history of any benign breast biopsies. So for instance, what we call non-proliferative is like your fibrocystic breast changes. And those have very little to no increased risk. Fibrocystic breast disease is really common in women. It's the most common cause of breast pain. When you look at other biopsies that are benign or non-cancerous that don't have any atypia or atypical changes, something like a fibroadenoma, which is the most common solid breast mass in women, and it's seen a lot in Black women, that slightly increases your risk for your lifetime risk for development of breast cancer. And then when we see biopsies that have atypia, which are not cancer, but they're kind of the precursors, the step before, there's a significant increased risk in development of breast cancer. For risk factors that we consider modifiable, meaning things that you can change, the ones I listed in black there are, we say cautiously that you can change those things. So like lactation or your ability to breastfeed, that actually has a protective effect. So that is a modifiable risk factor. Radiation exposure and breast density. And so one might think with breast density, which is how much glandular tissue you have in your breast, that you don't have control of that. But when we talk about how you can modify it is in the instance of taking extra hormones or hormone replacement therapy, that can increase the density in your breast. And so that is something that can be modified, because if you don't take it, then maybe you won't have that increase in the breast density. Alcohol intake, diet, obesity or weight gain, physical inactivity, those are all risk factors that you can have potential to change to lower your risk. We do know with family history that a woman's risk of breast cancer nearly doubles if she has a first-degree relative, meaning a mother, sister, or daughter, who has been diagnosed with breast cancer. But only about 5 to 10% of breast cancers are linked to those known genetic mutations that could be inherited from one's mother or father. Next slide. So how do we lower our risk? And I say lower and not eliminate, because we can't eliminate. There are factors, there are so many factors we can't change that nobody can tell you they can guarantee you won't ever have to deal with the breast cancer. Your risk is never going to be 0%. There are things that you can change. And the biggest is that we recommend that you are healthy, that you eat a balanced diet, that you maintain a healthy weight and exercise regularly, particularly with cardiovascular exercise, limiting your alcohol intake and refraining from smoking, reduce stress with yoga, meditation, exercise, and prayer, and then again, limiting that exposure to hormone replacement therapy or those extra estrogens. You can't change that you're a woman. You cannot change that you get older. We all wish we could, but we can't. Your family history is your family history. It's important for you to know it, but you can't change that, as well as your own personal history or your those natural exposures at like what age you started your period and menopause and all of that. Next slide. You have to click it one more time. So how is breast cancer diagnosed? Next slide. So the majority of breast cancers, as I said earlier, are found on routine screening exams or screening mammography. However, it's still important to be aware of your own breasts. So we recognize and recommend that you have self-breast awareness. That means that you should know how your breast looks and feels so that you know if there's a change. And if there is a change, you seek medical attention ASAP. You want to do self-breast checks. So if you have not gone through menopause, we recommend that you do a self-breast exam 7 to 10 days after the last day of your menstrual cycle. That's when the hormone levels have gone down. And then if you have gone through menopause, then we just recommend that you choose one day monthly and do that regularly. Next slide. And this is showing the breast exam. One important thing to know about the breast exam is that we don't expect you to diagnose yourself. We don't expect you to find any cancer or want to know. I get questions all the time about what does cancer feel like? And all I want you to do is be comfortable with how your breast feels, because you will notice a change and then you will come in and seek the medical attention. But during the exam, the important thing to do is, whether you are laying on the bed or in the shower or in the mirror, is that when you're doing your exam, on the breast that you're doing the exam on, the other arm needs to be up above your head. And the reason being is because this is going to layer out or stretch out the breast tissue, and you'll be able to feel if there's any lump in the breast. If you do your exam while you're sitting up and you hold your fingers like in between your thumb and first finger to try to do your exam, you may feel the breast tissue on top of each other, and that can often mimic a lump. Next slide. So early detection of breast cancer by mammography reduces the risk of breast cancer death and increases treatment options, including less extensive surgery and sometimes the option to forego chemotherapy. In recent studies, it has been shown that screening mammography significantly reduces breast cancer deaths by about 20%. So we recommend annual mammography starting at age 40 unless clinically indicated. And what that means is that if there was a family member, a first-degree family member that had early onset of breast cancer, then your screening may need to start sooner. So example, if mom was diagnosed at 39, then the daughter would start routine annual screening mammograms at 29. 3D mammography or tomosynthesis is really good, and what we recommend you have done if you have dense breast tissue. It can increase the cancer detection rate, and it lowers the false positive rate and also lowers the chance of having to be called back for more studies. With increasing age, we say there's no stopping point. There's no stopping age for mammography, but as you get older, over 75, but we all are living much longer now, that we basically assess the patient, their individual health status, their life expectancy, and we still do recommend an annual mammography. The only time we don't is if there's other medical issues that would not allow them to have treatment, or if the patient says, well, if something is found, I'm not going to seek any treatment. MRI is something that's used as well as ultrasound in addition to mammogram, not to replace it. But MRI increases cancer detection in high-risk patient populations and is more sensitive than mammogram and ultrasound in those high-risk patients. But mammogram or MRI is not used for routine screening because it has a really high false positive rate. we use that as supplemental too with women with dense breast tissue because it can increase the cancer detection rate as well, depending on that patient population. So these are just some pictures. It's showing the mammogram and the MRI. So the top left picture is the mammogram where the breast is in between two plates, and you get like an X-ray picture of the mammogram. And at the bottom, it's showing you that difference of the fatty tissue, which is basically a breast composed of all fat tissue, which is labeled as A. And then all the way to the right side of that picture is D, where there's a lot of dense tissue. And you can imagine trying to find something in that picture that's at D is significantly harder than if you're trying to find something in the picture at A. The MRI allows us to see through the breast through thin cuts, and we're able to see really fine detail as that picture below. Next slide. So sensitivity for mammography is 85%. It's not 100%, but it is the best modality for screening for breast cancer. When women have dense breast tissue there, that sensitivity decreases from 47 to 64%. So that's why we use those additional screening modalities like the ultrasound and the MRI, because we want to be able to make sure we see through that tissue. And that's also why we recommend 3D mammography. Women with extremely dense breast tissue have a 4 times increase in developing breast cancer, and it's more likely to be missed. And then women with dense breast tissue are more likely to have larger tumors at diagnosis because we are not able to see all the way through all of that dense tissue, and they might have lymph node involvement. Also, interval cancers are more likely to be found in women with dense breast tissue. Next slide. Okay. So after an abnormality is found on this imaging, then how do we diagnose breast cancer? We typically do it with a biopsy, and that's how we're able to get tissue diagnosis. It can be done with what's called a core needle biopsy, which is often image guided, or less commonly a surgical biopsy. And so that picture on the right is showing how we can get tissue for a diagnosis. The first one shows what's called a fine needle aspiration, in which we go in to collect cells or liquid. That's typically done when we have cysts or think that there's fluid there, and we can send that for evaluation. The second picture is the most common, which is a core needle biopsy. We use a larger needle, and that needle goes into the abnormality and pulls out tissue. In most cases, it doesn't remove the entire abnormality, but we're able to get a diagnosis, and we typically use an ultrasound or a mammogram or an MRI to guide us. The last is a surgical biopsy, which is not done. It's still done, but it's not as common. We like to know things before we get to the operating room, but if we have to go to the operating room, that's when you do the surgical biopsy, where we go in and take out the abnormality. Next slide. So just briefly, the types of breast cancer. The two types, the most common types of breast cancer are ductal and lobular. After we get our diagnosis, and that's the cells that are between the ducts and the lobules, but after we get our diagnosis, then we break it down and look at different characteristics of the cancer. We want to know, how is this cancer going to behave? How do we treat it? So what we look at are things like the hormone positivity or not. And cancers that like hormones that naturally occur in the body, estrogen and progesterone, when they lack those hormones, they tend to be more slow growing and less aggressive. So those are the favored breast cancers. Hormone receptor negative, meaning they will grow independent of what's naturally occurring in the body. Those are more aggressive, as well as the HER2 protein we look at, that when it's present, it will overproduce cancer cells. It makes it more aggressive. So if that is present, if it's positive, then those are more aggressive. But you can see in this pie graph that the most common cancers are the ones that are favored, the hormone receptor positive, HER2 negative. However, the HER2 negative, hormone negative, that's called a triple negative breast cancer, those are the most common in Black women. Next slide. So how we treat breast cancer. Treatment of breast cancer is multimodal. And what that means is there's not one option that can treat and be able to offer the cure rates that we have. So we use surgery, medicine, and radiation. So with surgery, which is what I do, it's either a lumpectomy or partial lumpectomy. That's the same thing. And that is going to be going in, taking out that tumor. When you take out the tumor, you take a little extra tissue with it. We don't want to leave anything behind, but you keep your breast. So if you look at that small picture there, I hope everyone can see it, but there, the dotted line, the black dotted line right along the edge of the areola, the colored circle, that's where I would make an incision and then go out towards that lump that's up in the upper outer part of the breast and then remove it. With a mastectomy, you're going to take out all of the breast tissue. When you take out all of the breast tissue, then if you don't have any reconstruction, which can be done at the same time, mastectomy, in most cases, if you don't do that, you're left with a flat chest wall. As far as medicine or the how we treat breast cancer with medicine, chemotherapy or hormone modulation therapy, which is hormone blockers. Not all breast cancers need chemotherapy, but it is a part of treatment. And the hormone blockers are for cancers that like hormones. Those are those hormone positive breast cancers. And then radiation is a part of treatment. Typically, or standard, it goes with lumpectomy, but in some cases of mastectomy, you need to have radiation afterwards. Next slide. So types of mastectomy. Typically the non-skin sparing, skin sparing, areolar sparing, or nipple areolar sparing mastectomy. And so the non-skin sparing is the one where we remove all the breast tissue, the skin and the nipple, and you're left with a flat chest wall. It's a flat closure. It's normally no reconstruction, and that's in a picture of the young woman, flowers on her head. And then the skin sparing is when we're going to take out the breast tissue and the nipple, but you leave the skin envelope to reconstruct the breast. And so that is the picture of just the single kind of orangey red tissue there with the nipple. That's exactly what it looks like when I remove it. And then areolar sparing or nipple areolar sparing is when we remove all of the breast tissue plus or minus the nipple. The bottom picture is a patient who had breast cancer and we did mastectomies on, and she had reconstruction done. And that was a nipple areolar sparing mastectomy. And also, keeping the nipple and areolar tissue does not increase your risk for breast cancer recurrence. Next slide. So when we talk about breast cancer treatment, we do have to talk about the mortality. Death rates have been steady in women under 50 since 2007, but have continued to drop in women over 50. And we think those decreases are due to treatment advances as well as earlier detection through screening. The overall death rate from breast cancer has decreased and continues to decrease by 1.3% per year. And that was from 2013 to 2017. And, you know, as I said, I think in the intros that breast is the most common cause of cancer in women. The second lead of cancer death women, and second to lung cancer, and that's for both men and women. No, I think you have to click it twice. So just a note too, while that's going, is, you know, not all women have benefited equally from these advances, which is seen in the striking differences between Black and white women. So why is there a difference in breast cancer mortality in Black women? Next slide. This graph is showing the incidence of breast cancer in women in the U.S. by race. And you can see that between the first two columns, the white and the Black women, that Black women actually have a lower incidence of breast cancer recurrence. So white women are still more likely to get breast cancer when you compare it to all other women by race. Slide. However, when we look at this slide, this is looking at the mortality rates. And what this is showing is that even though Black women are less likely to get breast cancer when compared to white women, they're more likely to die from breast cancer when compared to all women. And that is what we need to figure out. But this is just looking at the survival rates by stage and comparing it amongst different races and ethnicities. And it shows the second column, the light pink, in all 4 of the bar graphs are showing that non-Hispanic Black women still have a lower overall survival rate when you look at stage at diagnosis. So even with localized means it's just in the breast, regional means it may have gone to the lymph nodes, distant means it's stage 4 or gone elsewhere in the body. And in all of those different stages, Black women still have overall survival. And when we talk about the 5-year relative survival rates for breast cancer, for localized disease, it's 99%. Like, you should live from what we say is curable disease. But Black women are living or have lower survival rates. Next slide. And this is just showing that trend and repeating, what I'm saying is that Black women have that lower survival rate. And this is not something new that we've seen. This graph goes back to 1975. And we're looking all the way up to this picture is 2015, but it hasn't changed. And you can see that Black women are surviving less than when you compare them to white women in terms of breast cancer. We get all this information, and you can go to the next slide. With all of this information, there's no explanation. We need to know why. What is it that's causing these Black women to die from the same disease? Compare them to white women. And so lots of studies are being done to look at the disparities. You can just keep clicking. Racial disparities are seen in, there's several things, you can just keep clicking here. Many different parts of breast cancer care. We see it in access, we're seeing high rates, we're looking at tumor biology, we're looking at treatment to see what are those causes and why is there such a drastic difference with Black women when you compare them to white women. Cancer in Black women. 92% of Black women believe breast health is important. However, only 20% breast health with their family, their friends, or colleagues. We're just simply not talking about it. 17% of Black women have taken steps to understand their individual risk for breast cancer development. Black women are more likely to be diagnosed at later stages and with more aggressive forms, and that will limit treatment options when they're diagnosed at those times. At age 45, breast cancer is actually more common in Black women than white women. And at those young ages, there are often more aggressive forms of breast cancer and they're diagnosed later. Next slide. So this was stated earlier, but I'll say it again. The American Cancer Society found that Black women are 40% more likely to die from breast cancer when you compare them to white women. 40% from the same disease. This is just unacceptable. The cities have the highest mortality rate and the later stage diagnosis in Black women, and this is not in any order, are listed here. And Susan G. Komen is targeting, they have a plan to target these areas to amplify efforts to reduce the gap and those high mortality rates. And I highlight Atlanta because it's the home of our beloved Spelman. But recent information has shown that Atlanta actually is the city with the highest mortality rate and the late diagnosis. And prior to that, it was Chicago. Next slide. So there's a disparity. Disparities exist. Health disparities in breast cancer are differences in those breast cancer outcomes among the specific groups, such as ethnicity, socioeconomic status, sexual orientation, age, disability, and education. We know differences exist with barriers to screening and providing high quality care. We know that there's fragmented treatment, meaning some patients aren't completing their treatment and some are not being recommended the standard treatment. We know that they're diagnosed at later stage. Insurance status may play a part in the disparities, either not having it or not having enough. We know tumor biology and risk factors also play a factor in this, and there are differences that exist within them. Next slide. So when we discuss these disparities, there are disparities from the healthcare provider system level, but there are also patient factors that we have to take into account. So the patient factors that are associated with worse outcomes include lower income levels, having deficits in knowledge and health literacy, a lack of insurance or having financial burden, little to no contact with a primary care provider. A lot of times in some of these cities, a patient is like in an urgent care or an ER. And at that time, it's not going to be when someone recommends that they get screening studies done. Not having contact with the primary care provider can definitely cause a disparity. Patients who live in a rural area may provide barriers, as there may not be access to screening or diagnostic exams, as well as breast specialists. And then linguistic barriers, as well as cultural beliefs, may pose a problem in the lack of knowledge or understanding of the disease and treatment options. Lastly, there's a long-standing history of medical distrust, and it continues to play a role in patient factors that contribute to the worst outcomes. Next slide. So improving access to care. It involves overcoming many different types of barriers that patients may face. Patient navigators are something that has changed many systems, changed the game for a lot of practices in hospitals. Patient navigators have been shown to play an integral role in eliminating those structural barriers. They are able to provide assistance for patients in applying for insurance and state programs to get coverage for their treatment. They're able to help with access to screening and diagnostic mammography, as well as image-guided biopsies, making sure they get scheduled with the right providers, and making sure that they see all the providers that are involved in breast cancer care. They follow up with patients, kind of walk through. And they're also helpful in things like transportation and housing, which a lot of people don't know. Breast cancer with like walkthroughs, I guess, for approval for certain monies. They want to know if there's patient navigators to help for patients getting through treatment.
We seem to have lost Dr. Bowman for a moment.
Did we lose connection?
I think so. Her connection, I have a message that says she has low connectivity. We'll send her a message asking her to try to reconnect. Ariel, would we like to bring on our other guest while we wait?
Sure. So I'm honored to introduce our panelists of survivors for today. So first, I'm going to introduce Laura Titilola Ayabusi, eldest daughter of two Nigerian immigrants. She graduated from Spelman College in 2014 with a degree in economics and minor in business management. As a motivated business professional, post-graduation, Laura stepped into her calling and successfully landed several roles in the field of business marketing. While performing a breast self-exam in 2016, her life's journey was forever altered. After requesting a biopsy on July 19, 2016, what was assumed to be a hormonal cyst was confirmed as a ductal carcinoma tumor. At age 23, Laura, who had zero family history of cancer, received the news that she was diagnosed with stage 1 breast cancer. Laura recently celebrated her 4th year in remission on August 19, 2020. Yay. Since her diagnosis, she's created a YouTube channel and platform called Victorious 23, where she dives into the perspective of a young Nigerian American, African American, 20-something, beating breast cancer while still living out her best years. Victorious 23's mission is to educate her community, as well as encouraging men and women to actively advocate for health screenings regardless of age or theory. Alongside Laura, we also have Carmen Simon, is a native of Denmark, South Carolina. Mrs. Simon earned a biology degree from Spelman in 2002. She has a JD, an MA in public policy, and a graduate certificate in health policy from Duke University. She is admitted to the state bars of Georgia and South Carolina. After a visit with her general practitioner in 2014 for what she thought was summer allergy-related localized eczema, her general practitioner sent her over to have a mammogram. A pathology report showed abnormal cells removed during a lumpectomy contained an area of ductal carcinoma. After 2.5 months of radiation every weekday, Carmen's monitoring included an annual mammogram and an annual MRI. During her December 2016 MRI, invasive stage 1 hormone positive HER2 negative breast cancer was found. Following a unilateral mastectomy, reconstruction, and chemotherapy in 2017, Carmen has been cancer-free for the last 3 years. Mrs. Simon is a true believer in both mottos emblazoned on South Carolina State Seal. Animus opibusque parati, sorry, Carmen, if I totally messed that up, meaning prepared in mind and resources, and Dum Spiro, meaning while I breathe, I hope. So thank you to our two panelists here today to talk about their individual journeys with breast cancer, surviving breast cancer. Welcome, ladies.
Thank you for having us.
Thank you.
Yeah, so I know that I kind of gave an introduction to both of you, but I would love if we could have both of you kind of just give a brief overview of your own journeys. You know, when you were diagnosed, what age, what stage, how was it initially, your cancer initially detected, and how you felt when you first received the news.
Hi, Ariel, it's Dr. Bowman. I did get back on. I don't know if you want
Oh,
to.
hi.
Sorry.
Kiva, do you want to go back to her slides or
Sure, I can do that.
Okay, so we'll come back to the panel in a moment.
Okay.
All right, so we were on the next slide.
All right.
So most cancers are found on screening mammography. It's important for patients to be informed of those recommended guidelines for screening, as well as having access to screening. So we want to have health policy and for financial support to cover those screening studies. The Affordable Care Act requires all new health insurance plans, including Medicare, and this has been since September 2010, to cover mammography screening for every 1 to 2 years for all women with no copay or out-of-pocket expense for women over the age of 40. The National Breast and Cervical Cancer Early Detection Program provides breast and cervical screening for low-income, uninsured, or underinsured women. And these things are important because we want to be able to reach patients of many different areas or socioeconomic backgrounds that have their screenings done. There are many organizations, including sororities and churches, colleges, hospitals, medical practices that are offering the community educational opportunities to be informed of the guidelines recommended for screening. And then mobile mammography units like this one shown here, they're showing up all over the country to remove or assist in removing that geographic barrier to screening in attempts to reach those that may not otherwise be able to get screening done. Next slide. So if an abnormality is found on screening mammogram, then the next step includes the follow-up imaging and then tissue diagnosis. And many studies have looked at the time interval between imaging and diagnosis and then on to treatment. So this study showed that Black women had longer delays to surgery and oncology evaluation following surgery when you compare them to Caucasian women. And the difference with 89 days versus 64 days for treatment or at least diagnosis can be detrimental, especially when you take into account that Black women are more likely to be aggressive forms of breast cancer or to be diagnosed at a later stage. Next slide. So when we talk about factors that are associated with breast cancer delays in seeking care, we have to look at both the patient factors again, as well as the system factors. And this study found that women with less income who were not married and talked to God only about a breast change, to spirituality, were more likely to experience a delay in seeking care. The other factors that would cause a delay in seeking care are non-adherence to the recommended guidelines, having fear or denial, relying on alternative treatment options, making it a low priority or thinking that they're at a lower risk, maybe not having a family history, thinking that you're at lower risk to having breast cancer, and so thinking it'll go away also. Conversely, if a woman told someone, just one person, about changes in the breast, they were more likely to seek care and did not experience those delays. So when we want to talk about correcting that late stage of diagnosis, so as Black women are more likely to be diagnosed with breast cancer under the age of 45, which is over the age of the recommended screening at age 40, and they're more likely to be diagnosed with more aggressive forms or at later stage of disease. The American College of Radiology and Society of Breast Imaging recommends that Black women, and this is as of March 2018, that Black women are added to groups considered to be high risk for breast cancer. And so evaluation needs to be done, have their risk assessed, and this is done by a breast specialist or another healthcare provider, whether it's your primary care, internist, OBGYN, to determine if those screening practices actually need to start sooner than age 40. Next slide. So although Black women are more likely to be diagnosed with the more aggressive subtypes of breast cancer, particularly the triple negative breast cancer, and you can see on that graph, it's the second column, the largest dark gray block. It's associated with poor survival and a worse prognosis. But what we found when we're looking at this disparities is that when you account for those subtypes in biology, that Black women were still dying at a higher rate, meaning that those women that have that more favorable hormone positive, HER2 negative disease were still dying more than white women with that same disease. Next slide. So we need to look at treatment and why Black women are still more likely to die from this, quote, curable, less aggressive disease. There is a history of distrust of the medical professionals and medications and trials, especially in the Black community. There are some patients that do not complete recommended therapy because of that. We know that some patients or Black women are less likely to receive timely and guideline recommended surgery, radiation, or medical therapy. Patients aren't always being prescribed medications. They aren't always compliant. They're not always taking their medications. And then providers don't always hold patients accountable. So the follow-up, asking patients if they're taking certain medications, from many studies have shown that that's not happening. It's really important to provide education of healthcare providers on those cultural beliefs to help dissolve some of that distrust that exists, particularly in the Black community. And also we need to educate the community about the disease and treatment options so they can be informed and seek care for this potentially curable disease. So this study, I just want to point out when, I say that some patients aren't being prescribed medications. This is actually looking at for those hormone positive breast cancers. We do a test called a 21 gene risk recurrence score. So it looks at the risk of breast cancer to come back. And what we use it for is to determine if we need to give you chemotherapy in addition to hormone blockade. And so if you look at this graph, it shows that on the first set of bar graph that 30% or 31% of Black women were eligible to have the test done, and only 20% had the test done. So there's already you can see there's a discrepancy, there's a difference, and they weren't even offered to have the test done. So who knows what medical therapy they actually had and what would have been good to treat that breast cancer. Studies have also found that chemotherapy that would otherwise be recommended may not be based off of Medicaid versus in private insurance, high poverty, or education areas. Next slide. So with correcting these differences in treatment, things that we need to do on our end from the medical and the science research aspect is include more of those high-risk patient populations in research as it pertains to the tumor type or treatment regimens. We need most of the research or medical research that's done, those subjects they're not rich in minority patients. And one size does not fit all. We need to study the efficacy or the effectiveness of certain medications that are, quote, standard for breast cancer care in those different patient populations to see if there's a difference based off of race and ethnicity. The Breast and Cervical Cancer Prevention and Treatment Act, which was passed and founded in 2000, that does provide pathways to treatment services for low-income women through the state Medicaid. So that's helping and correct some of these differences in just access to treatment. But more needs to be done. And so the goal to dissolving all of the disparities is to achieve health equity. And health equity is the attainment of the highest level of breast health for all people, ensuring that everyone has full and equal access to breast health opportunities that enable them to lead healthy lives. This will result in everyone having access to screening for coordinated treatment and care by all the different specialists, having early stage at diagnosis, and we know that early detection saves lives. Next slide. So we know that differences in breast cancer diagnosis, treatment, and mortality exists among different patient populations, but particularly in Black women when you compare them to white women. As patients, you should be your own advocate. Know your individual risks, talk to your family and friends, get screened, and be compliant with routine screening. Be self-breast aware, know the changes that may happen in your breast and seek medical attention, and reduce your risks by changing your lifestyle and controlling those risk factors that we can modify. Next slide. Thank you. This is my daughter, Ava. Hopefully she'll be class of 2034. And this is us standing in front of my freshman dorm, HH. And
Our
the
data.
next slide. It's just if there are questions, if you want to make an appointment at Atlanta Breast Care, there's our phone number. You can visit our website at atlantabreastcare.com or our Facebook page. There's also the QR code where you can put your phone right up there now and it'll take you to the direct link to our webpage. I think we're going to do some questions later. So, right?
Thank you, Dr. Bowman. Yes, we will have questions after our panel. Any questions you all have, please leave them in the comments and we will have them for Dr. Bowman to answer. So coming back to our panelists, the floor is yours, ladies. So again, give us kind of a short, brief description of, as brief as you can. I know it's a lot to put in your journey as a breast cancer survivor. So I'll start with Carmen. You want to go?
Sure. Good evening, ladies, and thank you for having me. I have a rather convoluted way of coming to a breast cancer diagnosis. My experience with breast cancer was that my maternal grandmother had breast cancer, went into remission, was re-diagnosed a little bit later, a couple years later, and then passed away my junior year at Spelman. And so that was the totality of my experience with it. And there was a lump involved. With me, one summer of 2014, I was 33. I had eczema, localized eczema. I always get eczema with my allergies, like that's a thing for me, but typically it's not localized. And I was telling a friend about it, and she said, you should probably go get that checked out. I went to my primary care physician, and that combined with a couple other symptoms had her send me to have a mammogram. They saw nothing on the mammogram, but because I was there for a reason, we went on. I had an ultrasound biopsy. They found abnormal cells. And so the suggestion was to have a lumpectomy and have those removed. In the pathology for the mass of abnormal cells, there was an area of ductal carcinoma in situ, and the margins were very close with the surgery, and so they recommended that I have radiation. Following that, I was followed up every 6 months with a mammogram. Alternate 6 months, I'd have an MRI, 6 months mammogram, next 6 months MRI. On the, I guess, fourth follow-up, the MRI did detect a different mass in a different area of the same breast. And after ultrasound biopsy, turns out that was stage 1 invasive breast cancer. And so at that point, I had a unilateral mastectomy, reconstruction, and because of there's a test that they do on the tumor to determine whether or not you're at a high risk for recurrence. It's called an Oncotype DX. I had that test. I was at a high risk for recurrence, and I had a recurrence. So they suggested that I have chemotherapy. So I had 4 rounds of chemo, summer of 2017. And following that, I went on tamoxifen because my tumors were both hormone positive, HER2 negative, and since tamoxifen is hormone therapy, it would work to help prevent another recurrence of breast cancer. And have been on, up until this summer, I was on tamoxifen. So that's my story.
Thank you for sharing that. Laura, could you tell us your Victorious 23 story?
Oh, yes. One, Carmen, I love being around other survivors, warriors. So kudos to you for your 3 years. For me, where to start? Graduated school 2014. As I mentioned, living my best life, ready to change the world, as all of our Spelmanites know. And doing a self-exam is what saved my life. So I am a huge advocate for every woman, every male to take the time to do it every single month, whether it's you marking it on your calendar after your menstrual cycle. Take the time to definitely look at your body. We know our bodies better than anyone else. We are around our bodies. We are living in our skin. So you can definitely tell if there's anything weird going on. And for me, coming out of school, focusing on getting into my career, focusing on just my next steps, I can definitely attest to not putting my health first. It wasn't until I was doing just a self-exam, and that must have been God's calling to tell me to slow things down. And I just decided to do a self-exam, and I felt something. My mother immediately was like, you need to make an appointment, go and see your doctor. My mother also sees the same physician that I see. And when I came into the office, she also felt the same area. I could actually feel it. So for anyone that has any questions of like what it feels like a pebble, something hard, roundish for me. Again, everybody's journey is very individual to them, but for me, I could feel it. It was on my left side. And my physician also felt the same thing. But knowing my mother's background and her history of having hormonal cyst, my physician immediately thought that this was possibly the same exact situation. This is a hormonal cyst. We'll track it for a few months. If it's still there, come back in, and then we'll reevaluate the area again. A few months passed. My mom was like, "Is that thing still there?" And I was like, let me get my life. So after doing another evaluation, I found the bump was still there. So I immediately decided to call a breast specialist within my doctor network. They offered me the option, after an ultrasound was performed in office is when they were able to evaluate if the area was full of liquid, which would be the cyst, or if it was more of a solid mass, which they found it was more solid and there was no liquid. So in that moment, for me, I was just like, this is not supposed to be here. Let's get the biopsy done. Let's figure it out. They offered to take a slice of the biopsy or to remove the whole thing. And I went ahead and pulled the trigger. I said, take the whole thing out. It's not supposed to be there. Let's find out what this is. It was it was July 19th when I came into the office, and my specialist told me that it was cancer. It was a tumor. She was able to calm me down, but in those moments, definitely learning at 23 that what I was feeling this whole time was in fact a tumor. It was not a cyst. It was not a hormonal cyst. This was something way bigger. That for me was a life-changing moment that cancer has no face, no age, no limit. I had never had a breast screening prior to me finding out everything happening in my breasts. I remember going to my doctor's office anytime like I just felt weird after a menstrual cycle, or there was a time that I did experience some lactation, or I don't know if that's the real word, but I had some fluid, some liquid some discharge coming out. But again, these things are just checked off the list based upon your age, based upon just, your race, hormones. It's the hormones in your body. So after finding out that it was cancer, my surgeon was amazing. Another thing I would love to stress to anybody is really having a network of doctors that truly look at your case files, looks at your medical history, and really evaluates what we're doing here. And I could tell from the door that my surgeon stepped into my situation looking at everything, looking from what I have mentioned in prior visits, just looking at all history, which is very important to me because I have not worked with a few doctors simply because I felt that they did not look at my case and really see me for who I was and understand me, 23, Nigerian, having zero history in my family of cancer. This is not the norm here. So I do not want to be treated as a normal statistic. I need to understand I need to understand that you understand how serious this is to me. So my physician, my specialist definitely stepped in. She mapped out what the options are. She offered a lumpectomy, which is where they take out the tumor. They still keep your breast intact, as Dr. Aaron had mentioned. And then there's the other option of mastectomy where they remove the breast. Not going to lie to you guys, the second I heard mastectomy, I bust out crying. The thought of me at 23 losing my breast, like I haven't even thought about having a family or like whether I need to now start saving my eggs. These conversations were all streamlined pretty fast for me personally. I decided to go with the lumpectomy. I got a lumpectomy surgery after the biopsy. They also did a lymph node surgery because my tumor was found on the left-hand side. They checked my left lymph node to also make sure that no other cancerous cells had moved from the breast outward. That's a pretty good tell that there may be cells other places of your body. I was ecstatic. My mother and I were ecstatic when I got my phone call in August 19th specifically, telling me that there were no more cancer cells in my body. Yeah, so that was a moment. I went ahead and after my surgery, I did opt in to get all of my genes tested. My results came back that I was HER2 negative. I was hormone ER positive. My Oncotype score, which Carmen mentioned before, is a scale that they use to measure how aggressive your cancer cells are. My cells landed on it was like a 16. I believe the chart goes to 100. But if your score is kind of over the 25 number, they definitely advocate for you to do chemotherapy. Basically, your Oncotype score really maps out how you're going to go through your therapy. I necessarily didn't need to go through chemo, but I did have, and I am taking hormone therapy. I take tamoxifen. I've been on tamoxifen since I stopped radiation. Radiation was also something that I had to take as therapy, simply, going inside the body. It's just a suggestion. And so, yeah, my tumor was not super aggressive, but I was stage 1. I am taking hormone controlled prescriptions now. The advice also differs based upon my age as well. I, not having chemo, but doing radiation, I also had a specialist that, again, looked at my records and was just like, you're not a 50-year-old white woman. That is what is in the books for a lot of therapy and treatments for breast cancer today. We're looking at books and we're reading reports that are so dated. And again, we're living in 2020 where we already know anything can happen. So I really appreciated having, again, a specialist to really look at my file. And we definitely had a very aggressive approach with my radiation. Radiation is typically, I think, around like 6 weeks is the average. My round of radiation, I went about 8 to 10. I finished right before Thanksgiving. That was a great day because then I got to eat well and I definitely had an appetite for all the goods. But after radiation is when I then started my tamoxifen. And the advice that they are now giving for tamoxifen has changed. I have a close friend of ours who was instructed to take tamoxifen for 5 years, where for my case, I am being suggested to take it for 10. So I will be taking my tamoxifen for 10 years. Let me listen to the doctors. And when I am done and I am off of my tamoxifen, I will then start thinking about having children and living my best life continued. So cancer definitely touched me in a very odd and unexpected way. But it has also completely changed who I am as a person, my spirituality, my mental state, even understanding the woman's body, even just so much better. I have such a different appreciation for the body. And so it's so important to me to use my platform, Victorious 23, to make sure, one, that everyone is advocating for everything that you want done. I've had doctors tell me, oh, we're not going to do the mammogram. Oh, we're not going to do the MRI. And I've had to call my insurance company and make them aware. I'm requesting this, and my doctor has also requested this. And regardless of my age, I'm getting that mammogram done. So there's conversations like that are important for our community to know. It's so important that you advocate for yourself, because there are a lot of people, and unfortunately, that are looking at us as a number, as a statistic. You're just another patient on the floor. And I don't want to be looked at that way. So that's my story. I feel like I covered all bases, but I love to talk. I do have my platforms. I am on YouTube. If anyone has any questions, feel free to reach out to me. Even if you are not the soldier in the fight, if you are someone that's trying to aid someone that is currently in the fight, I love covering those conversations. I love also just speaking to those that just want to know, how do I ask that question without it seeming offensive, or without me being, just mindful of the topic? Because cancer, it scares some folks. When they hear that C word, they freak out. So yeah, I'm here as an open vessel to anyone who needs additional support, wants to talk more, want to learn more. But definitely check your titties, check your tatas, and do it regularly. And also make sure your friends and your family are also doing it, because
Doing the same.
it's a conversation that we need to talk about all the time.
Yes, definitely agree. Thank you so much, Laura, for sharing your story. I do have a couple of questions for you all. Just Carmen, can you just speak about any obstacles that you may have faced during your treatment process? I know you also spoke about being on tamoxifen and going through chemotherapy and radiation. Can you speak a little bit about that and how you overcame any of those obstacles?
My biggest obstacle really was myself, and learning to be my best advocate. I had to break up with a few doctors. I had to have some conversations with some practice managers, because I didn't. It was both on my behalf and on the behalf of the other people sitting around me. I didn't particularly enjoy the way that they treated people. And so those were, I am a quiet person. I sit back. I listen. I write everything down, which is why I had to break up with the doctor, because we got him on some things. And, I just had to learn to speak out. I would say that one weird obstacle for me, I've never thought of myself as a vain person, but my job, my very last job, I worked for the South Carolina General Assembly, and every last meeting that I worked was live streamed. And so to go through chemo and lose your hair while knowing that you would be live streamed on the internet and public television for your job every day was, it revealed that I might have a little bit more vanity than I thought I did. But I, and also just really talking with people and asking for help, because once I asked for help, I got help. My husband was awesome. He was not my husband in 2014. He was my boyfriend, but he was still there. He was great. In 2017, we were then married, because we were, we had, before my second diagnosis, we had decided to try to have children. and we'd been trying for 1 month. And so then I got the second diagnosis. And so that was just like having a partner that was really a partner in the whole thing was good. And you know, helped me kind of cross over some things. And I asked him one day, I was like, why are you so gentle with me? Why are you so understanding? Even in like helping me with, after you have a breast surgery, they insert drains and they have to be dumped. It's not, you know, it's not for the faint of heart. It also hurts the person that you're doing it to if you're too rough, but he was really good with that. But he said he watched his granddad with his grandma during her breast cancer treatment, and that's how he learned to do what he did. So I am forever grateful for that. So biggest obstacle, myself, and speaking out for myself.
Wow, thank you for that. Yeah, the importance of speaking out and you breaking up with those doctors. Kudos to you for taking that step, because there are a lot of sisters that sometimes they just they take it, they just deal with it instead of finding another physician that's really on their side, really on their team. Laura, I know that you said that you had an amazing specialist. How did you go about finding that specialist? Is that just like a match made in heaven? You went and found a specialist and then it was great, or did you also go through some kind of breakups as well?
So my surgeon, it was a match made in heaven. She just happened to be leading all of women's health for Chestnut Hill Hospital. And she just had a really great, she just was a great person in general. And then again, really seeing how from the door, she just took this whole thing under her wing and was like, listen, I'm gonna try and save your titty. I'm gonna try and save the nipple. I'm trying to keep everything intact. This is not supposed to happen to you. So her really just coming to terms with just like, I got you was very assuring for me. As far as my other doctors, I definitely had my hand in that. I met the medical oncologist that also was in the same network for Chestnut Hill, and I did not appreciate him at all. It was just not at all a great experience. I came into the waiting room. I'm waiting in the room now. He has no idea why I'm there, and immediately jumped to chemo, and I was like, no. So I also had my hand in selecting my radiation specialist. He was by referral, excuse me. So yes, but in the climate of 2020, though, I recently have been looking for a new medical oncologist who is African American, as I'm now starting to think also about building a family in the next chapter of my life. I will start to add in now another doctor to check my eggs, make sure all of that is great. But I definitely would stress making sure you have doctors within your network that you are very comfortable with, that you can also tell they're really looking at your paperwork and not just setting you as a statistic. It's so important.
Thank you. Thank you for that. So I'm going to ask you, sisters, one more question, and then we'll move into Q&A. So Carmen, what advice can you give to sisters that may be dealing with a diagnosis right now, or even just future advice you would give to someone who may be going through a diagnosis?
This is going to sound a little crazy, but write everything down. You know, and take a notebook with you to your appointments. Write down what your doctors are saying, because in my case with chemo, there's something that they call chemo brain. It is actually a real thing. You begin to forget things. So that's like a practical kind of thing. It also helps when you receive. I have bins of medical bills to just sort of help you bring you back to what treatments you actually received and what didn't happen. So write everything down. But the other thing is, for me, like being outside, being in nature, has always been something that's helped me with stress. And so I think as a general rule, you should be active. And in my head, as a general rule, you should enjoy nature when you can.
Yeah.
But for me, the thing that kind of helped me keep my stress level down and keep my head on. I'm not saying you have to keep your head on. You should be able to cry, yell, scream, punch a hole in the wall if you can fix drywall. Do all of that. But my way of coping was outside on a mountain, by a lake, by a river. I had to cross a river every day to get to radiation. That was awesome. My oncology practice was across the river from my office. And then, spent a lot of time on my yoga mat, doing a lot of heart opening things and just listening. It quiets you down, it slows you down. My life is, my life is not what I imagined it would be. I did not imagine a cancer diagnosis in my mid-ish 30s, and going into my late 30s. And so just breathing. And there are things that I still do today. And the bonus with yoga, hiking, all that stuff is it's preventative. So.
Thank you. Laura, same question to you. What advice would you give to sisters that may be dealing with diagnosis?
I feel that my involvement with different breast cancer organizations has really shaped how I have looked at this diagnosis. Speaking to other women who, I might get a little emotional, y'all. Speaking to other women who have gone through their individual fight and have stories of courage that you couldn't even imagine. That to me, also speaking to God every day, just having moments of just stillness, because it is very important. You will find a lot of moments, especially on these type of journeys, where you may feel like you're by yourself and no one else may understand. But having those moments of just stillness where you can talk to God, what's going on? It honestly brings a level of warmth in those spaces that it may seem so dark. I also definitely recommend physical sports. I love yoga. I played soccer for all my life. Just being outside is just something about being outside in nature. Just honestly living your life just as you were, not at all feeling that this diagnosis stops anything, because I can be the one to tell you that this diagnosis, if anything, has shaped who I am, and I'm stronger. I'm like, my mental capacity, my physical capacity, like I feel invincible. So it's a gift. It's not so much a curse. I think for those that are definitely going through the journey, understand that it is a very individual journey to you. And that there is victory at the end of the lap, regardless of what the diagnosis is. You can gain strength and clarity and so many different things just by slowing down the pace and really focusing on you. I took my journey very personal. I definitely took time to just evaluate everything about myself, down to my diet, down to even the peers that I keep in my inner circle. At the time I was diagnosed, I had someone who I was talking to, and things like this definitely are eye-opening events where you get to see those around you, how they show up for you. So for me, a very personal journey, but I think that just having moments of stillness and just reminding yourself just who you are, like just reminding yourself that you are woman, these breasts are yours, this body is yours, regardless of the scars that are left behind, those are also yours, and owning all of that, and just really just appreciating every single day, every breath, everything. There's a blessing in everything that you can look at. So for me, just really keeping my mind focused on what is ahead and not questioning what I'm currently going through is what truly kept me going and kept my mind just forward. And it just kept me in a healthier space. So just remain in healthier spaces during this time is the most important thing that I would share.
Beautiful. Well, thank you, ladies, so much for joining us today and sharing your stories as phenomenal women who beat cancer with just strength and grace. We're so thankful to have had you all with us this evening. So I do have just a couple of questions before we end for this evening. These questions are for Dr. Bowman. We had one question that said, every time I get a mammogram, they tell me I have very dense breasts. No one has ever said a 3D test. Is that something that happens if there's a concern, or is that something I should start to seek from a different doctor?
If they're telling you have dense breast tissue, then you should have a 3D mammogram. Now, 3D mammograms are not done, like every breast center, every place that you can get a mammogram does not have the capability. They're not everywhere, but you should request it. So it does not mean it's not for something when it's not a test that's done when there's a problem. It's a test that should be done when you have dense breast tissue. And if they can't offer you to have a 3D mammogram, then you can find another place that can. You can also demand that they give you an ultrasound, or you can find a breast specialist in your area, and then they can then lead you down the path and get you to the right studies that you need to have done. Currently, it's not recommended, or it's not mandated in all states, but I think it's 38 states right now are mandated to put on your actual report for your mammogram if you have dense breast tissue or not. And so that you are informed of it, and that you know that when you have dense breast tissue, that lowers the sensitivity of a mammogram, and so that additional things can be done. So if you are not able to get it done, find somewhere to be able to get that 3D mammogram done.
Thank you. And the last question that we have is, Dr. Bowman, can you share what tests we should ask for even if insurance doesn't cover it?
Well, so if a test is recommended for you, so if your screening mammogram is done, and like with young women, you might have to fight a battle to get a mammogram done, because it's not the standard. It's the sensitivity is going to be lower because you're more likely to have dense breast tissue when you're younger, and so it's not the recommended is based off of the guidelines, right? To be under 40 having a mammogram done. So you might come to an obstacle. Mean that's the stopping point. If a test is recommended, so like if I order a test for someone to have a mammogram who might be under age 40, and I get, the backlash of, no, we can't do it, then I am the one that's advocating for my patients to get it done. And if I have to talk to insurance companies and do peer-to-peer reviews, then I will do that, because I know what needs to be done as the specialist. Insurance companies don't know. And that's our job as physicians, to fight for our patients. And so having someone that's on your side, that's going to take you as an individual and not as a number, is going to be key in helping you get through those obstacles that may come up. Mammogram, MRI is typically recommended for younger women, although it's expensive, so insurance doesn't want to pay for it. So they will give you pushback as well for getting it done. Ultrasounds, not as much, because, and there are a lot of breast specialists, including like in my office, I do ultrasounds in my office. So, if you find a breast specialist, you can go to the breast specialist and have those things done if they have the ability to do it in the office. But if you get pushback, you're your own advocate. You've got to ask questions. You've got to demand. And then if you have that specialist that's on your side as part of your team, then they're going to do it for you too.
100%.
Yeah, I completely agree. Well, thank you, Dr. Bowman. We really appreciate you being here and educating us on breast health and what we can do to make sure that we're keeping those modifiable risks healthy. And so with that, I will hand it over to our chair of the Health and Wellness Committee, Vanessa Spearman McCarthy.
Good evening, everyone. I want to thank you so much for taking the time to be a part of our program. And I cannot thank you, Dr. Bowman and Laura and Carmen, for your time and your testimony and your knowledge and expertise. You really have touched us in a deep way. And reading the comments from our sisters who have tuned in, I know you have touched them as well. You know, I just can't tell you how humbled I am that, you know, when we called you, you said yes. You didn't ask like, well, what's going on? You just said yes. And that's what we as Spelman women do. So from the bottom of my heart and on behalf of the entire committee, we thank you and God bless you. And I think, you know, with being mindful of time, I think that we're at a stopping point. I think that we're okay. Check your comments for those of you who are signed in, because we do have some information, and this session has been recorded. So we'll be able to provide that to you, and hopefully the comments will come through too, because we have important websites as well as email addresses. And with that, President Kiva Wright-Berry, do you have any other comments?
No, not at this time. As Vanessa says, this has been recorded, and we are contemplating putting together a YouTube page for the association where we can post events such as these so that people can come back and get them. But it will be available on our Facebook page for anyone to review at that point. But thank you again, everyone. We certainly appreciate all of your participation. We're thrilled to have so many sisters online with us listening to this information. Hopefully they will share it with others so that we all can have good, strong breast health and have strong health awareness. So thank you again, Vanessa, Ariel, Aaron, Carmen, Laura. It's been a great experience for us all. Thank you.
With that having been said, good night, all.
Good night.
Good night. Thank you.